post-lunch session. I invite you, Dr. Mahendranath, on the stage. To accompany him, I call upon our spine surgeon, Dr. Surendra Kodladi Shetty. He is a consultant spine surgeon. He is an orthopedician, completed his MS Ortho from KMC Mangalore in 1999, finished his fellowship in minimal invasive spine surgery, a good surgeon of spine and a wonderful person. And he is practicing his spine surgery from 2007 onwards in Bangalore. I hand over the stage to both the chairpersons to organize the debate.
Colleagues, we have an interesting debate. Dr. Bhakuni, Brigadier Bhakuni, Visist Seva Medal winner, is one of my senior rheumatology colleagues, and I know him for more than 2 decades in the Indian Rheumatology Association. He is one of our brightest stars in the Indian rheumatology scene. At the moment, he is based in Delhi, in RR Hospital, one of the premier hospital in the army and the research wing actually. And he did his MBBS from King George Medical College, Lucknow in 1980, MD General Medicine from Armed Forces Medical College, Pune, and he did postdoctoral training and rheumatology in one of the premier institutes in the country, Sanjay Gandhi Research Institute, with one of my close friends, Professor Ramnath Mishra, who has mentored a generation of rheumatologists, including Chandrasekhara in this country. And he has worked in several places, different army situations, published a lot of publication, both peer-reviewed and national journals. And he is an extraordinarily good speaker and a debater actually.
Sorry.
I am looking forward to Bhakuni's speech. On the other hand, we have Professor Kiran K.V. Acharya. I think I am meeting him for the first time. He is from Manipal. He is the professor of orthopedics in Manipal. He did his MBBS from Kasturba Medical College in 1992, his MS Orthopedics from Kasturba Medical College, Diploma in Trauma Management from Israel, and Principal Advanced Fellowship from Duke University in 2008. He has several peer-reviewed publications. I was very happy in the inaugural session when Acharya mentioned people, he was very modest. He said people who are sitting in the front benches, they become rheumatologists. People who are sitting in the last benches, they become orthopedic surgeons. He also used to sit in the last bench along with Jai Prakash, my classmate, sometime for a different reason actually. But down the line, 20 years, I can say the rheumatologists probably are still where they are. I am still driving a old 5-year Mahindra Logan. 20-year junior orthopedic surgeon to me like Sanjay Patil, Sharan Patil, I don't know about him. They drive their BMW and Mercedes Benz, you see. So what is the criteria for that, I do not know honestly. I am looking forward for the debate, Acharya. Thank you.
Good afternoon, ladies and gentlemen, and thank you for the very kind. So-called debate is hardly a debate because we already have out-of-court settlement, me and Dr. Acharya. So please don't expect any fireworks here because settlement is a settlement. Anyway, despite that, I like to speak about osteoarthritis, the medical management of knee joint particularly, and of course later on some questions will arise. So my topic is the medical management of osteoarthritis, whether the joint to be preserved as far as possible or not. Well, osteoarthritis is prevalent world over, but India takes the cake. In US and other countries, 10% of the population above 60 years of age, they are suffering from osteoarthritis. Whereas in our population, we get the patients 45 years, 50 years, especially the ladies, maybe 55 years or so. So we have everything early in this situation. And the problem with osteoarthritis is that there is no known cure for it. So why we are discussing osteoarthritis? Because the cartilage is the key element here. And what is unique about this articular cartilage? It doesn't have any blood supply. So whichever amount of drugs you give, it hardly reaches the cartilage. So there is no repair, no effect on cartilage. That is the biggest drawback. Number 2, it has no neural elements. That goes in our favor because we jump, we run, we dive, we do so many physical things, but there is no pain. because of this good cartilage which does not have any neural elements. And 60 to 80% of it is water. So, I mean, you can see that how soft it is. In pathogenesis, the biggest risk factor is age. More the age, more the risk factor for osteoarthritis. Why? In our childhood, we again do so many physical activities, the wear and tear of cartilage goes on. But at the same time, the repair takes the balance. Here at this side, the wear and tear and the repair is always on the balance side. But in young patients also we see osteoarthritis, but basically they are secondary osteoarthritis. In which young patients? Those with unfavorable biomechanical environment like trauma because of the sports activities or maybe some road traffic accident or so. So that is what I was telling you. There are two cases. Basically, after the wear and tear, the repair attempt is there, or because of the age, advancing age. That's why we have osteophytes, the extra bone formation. But gradually, the repair attempts goes in vain, and enzymes they erode the cartilage. So what happens in the result wise? If you see the erosion of cartilage, the bone-to-bone contact is there, especially at the squatting position or at the cross-legged position. Then the patients, they feel pain. So there is no cure for that. How do you diagnose? Well, as usual, we have to suspect that osteoarthritis is there in patients who are elderly or maybe 45 in our case, and who gives a history that, Dr. Saab, whenever I get up early in the morning, I have that gelling effect. I cannot move as frequently as I move at the later part of the day for few minutes, maybe 2 minutes, maybe 5 minutes or so. But after 5 to 10 minutes, he becomes absolutely all right. He moves around freely till the time there is a physical exertion. So now, after suspecting clinically, what do we order? We order X-rays. What mistakes we make? We do not write which view or how the position should be taken. Usually, it is a PA view, lying down view. Please ask for standing view. Horsburgh book of rheumatology, the textbook says that it should be standing PA view, so that the penetration of the X-rays is better through the knee joint space, so that we can see the structures in a better way. So please ask for standing X-ray, either PA view or AP view, both knees. Never ever ask of a single knee. Now, how do you treat them? There are many methods of treatment. The American College of Rheumatology came back with some recommendations, and look at the recommendations. The story is different in our setup and its story is different in their recommendations. They have conditionally recommended should use one of the following, means paracetamol, oral NSAIDs, topical NSAIDs, tramadol or intra-articular steroid injection. Conditionally recommended should not use the following, which everyone uses. What are those? Chondroitin sulfate, glucosamine, topical capsaicin. And no recommendation whatsoever for intra-articular hyaluronics, duloxetine and opioid analgesics. Gentlemen and ladies and gentlemen, the story is entirely different in our setup. We do absolutely opposite or ulta to all these recommendations. The non-pharmacological recommendations are also there, like exercises and other things which I will talk to you later on. So let's come first to the pharmacological recommendations. As Dr. Benjamin told, one of the best drug is paracetamol. But it has a low level of analgesics. We have to give higher doses. But the study shows if you give more than 3 grams per day, there are more chances of GI side effects and multi-organ failure. Mind you, these are theoretical risks. As he said, you can easily give it to 4 grams or so per day before you start your patient on NSAIDs, because most of the patients, they do not come to the doctor for osteoarthritis initially. Maybe at the age of 60, 65 or 70, that time to give NSAIDs is not, it is recommended, but it is not that good. So if the patient does not respond to paracetamol, then you give NSAIDs, oral non-selective. The question arises, which NSAIDs? Let me tell you, all NSAIDs are equally good or equally bad. It all depends upon the choice of the patient, choice of the doctors, and depending on their age. So, and I like to mention that naproxen had a better cardiovascular safety. In a patient of IHD, if you have to prescribe NSAIDs, please prescribe naproxen. It is a little better than others. Diclofenac causes hepatic enzymes, raise in hepatic enzymes, than others, but never ever combine two NSAIDs. We have seen prescriptions from general physicians, orthopedic surgeons like Endocit plus diclofenac plus piroxicam if the patient is not responding. Never ever do that. Do not harm the patient should be our first motto. And of course, if you are prescribing NSAIDs, don't forget to prescribe proton pump inhibitors also, because the Cochrane review showed that it really helps to curtail the GI side effects of NSAIDs. Now COX-2 inhibitors, they are better or comparably tolerated. They are not better than non-selective. Their adverse side effects are almost equal, except they have less GI side effects but moderately high cardiovascular risk. So as I said initially, all of them are equally good or equally bad, barring very, very few differences. And it's a topical. In a TV advertisement, diclofenac, sodium and Volani and other things, it comes into advertisement. They are not bad, let me tell you. They are comparable efficacy of topical and oral NSAIDs for knee osteoarthritis. You may not prescribe him oral NSAIDs. Prescribe some topical NSAID that will help, and it will help for lesser side effects systemically and hardly any local side effects. Again, for theoretical purposes, and all these studies, they showed that they have some local side effects. Opioids. Dr. Benjamin, I think he covered it very beautifully, but 2006 review showed that tramadol has a better efficacy on that. But mind you, never prescribe tramadol in higher doses. Tramadol comes in two forms, as I told you, paracetamol plus tramadol combination in 36.5 milligram or 18.375 milligram. But the word of caution is that avoid prescribing them to elderly people. Why? Because of the sedation and dizziness. I myself took, I'm not that old, but I myself took 18.5 milligram with paracetamol. Mind you, I had severe dizziness after half an hour. I had to call my colleague Kanu Shanmugan to sit on the chair and look after me for the next half an hour or so. The word of caution is that patient may be susceptible for dizziness or sedation, especially the elderly one. Otherwise, you are free to prescribe all these drugs. Duloxetine, not used very often in osteoarthritis, but mind you, is a very good drug. Why? It is antidepressive also. So most of our patients, elderly gentlemen, staying alone, children are abroad, you can increase the dose, but the patient will bless you both. He says, Doctor, I feel so good. I have got a little pain now, but very less and very uncommonly prescribed drug. Capsaicin. Well, the interesting thing about capsaicin is that it basically is a counter irritant. It tends the patient to forget his pain and enjoy this kind of burning sensation, all those. So whether it's distraction or attraction, I don't know, but it helps. Next come in the series are three drugs, chondroitin, diacerin and glucosamine, which are not collagen formation, a significant but small effect on slowing the rate of decline in joint space width in patient with knee osteoarthritis. This study was published in Hochberg textbook of this in 2008. So people started writing these drugs, but not very common nowadays. Few studies showed that it does improve the space reduction over 2 years. Meaning thereby, if you are writing this drug, please prescribe for minimum for 2 years. Do not ask the patient to stop it. Still, after so many conditions, it is one of the self or over-prescribed drug by the physicians as well as by the demand of the patient. They themselves take this chondroitin sulfate. Next drug is diacerin. Again, this is basically IL-1 inhibitor which reduces the cartilage breakdown. It has some efficacy. The side effects were, if you prescribe more than 50 milligram twice a day, it used to cause diarrhea, especially in elderly individual. Nowadays, this drug has been banned or not prescribed in Western countries. In our countries, still few of them still prescribe this drug. Now, most controversial drug, glucosamine sulfate. I am sure your patients whose children are there in US or UK, what do they come with? They come with a jar. Doctor, my children have sent in glucosamine tablets. Should I take them or not? My answer is very simple. Are they free or your children have charged you? They said, no, doctor, it's free. I said, take it. If they are to be, which are not free, do not take them. But for the vegetarian patient, never ever tell them that it comes from the exoskeleton of shrimp, lobster and crab. So it's not a vegetarian drug. It's a non-vegetarian drug. The glucosamine sulfate is available commercially as a pharmaceutical drug in Europe. Mine is sulfate, not chloride. Whereas this drug is not registered in UK and US. That's why whatever the drugs or the jars of glucosamine you get from US, they are glucosamine hydrochloride. It is next statement. So glucosamine hydrochloride, which is not effective in case of osteoarthritis. But still the patients they take it, and what is effective is glucosamine sulfate, which is efficacious, and the studies have shown like this. But at the same time, if you ask the patient stop glucosamine hydrochloride or sulfate, the patient say after 3 to 4 days, doctor, I am having pain. Why? Because after 6 to 8 weeks of use, the glucosamine also acts as a low analgesics. So he has withdrawn his, you have withdrawn his paracetamol, his NSAIDs. At least give him ask him to continue this. If not as a repair of the cartilage, as a painkiller, low painkiller. So these drugs, they have still, these studies showed they definitely have a role in decline in joint space narrowing, as well as these kind of patients which were followed for next 3 years, they showed that there is a reduced requirement for knee surgery. So the jury is out in the sense, if the patient is already continuing glucosamine sulfate, not the timing, no? Okay, good. Corticosteroid intra-articular. Well, ladies and gentlemen, if you want to be blessed by your patients, use this injection. Wonderful injection. Along with 2% lignocaine or xylocaine, the patients they come in stretcher, if not in stretcher, in wheelchair, inject the joint. The patient stands within 2 minutes. But the next question is, Doctor Saab, I'm all right now, how long the effect will remain? Answer is again simple, 2 days to 2 months. Never ever say, we are all right. Because we have seen the patients who come in a very late stage, grade 4 osteoarthritis, but they are coming in wheelchair. Inject this injection. The lidocaine effect remains for 2 days. So you give the guarantee for 2 days you may not have pain, or maybe extend up to 2 months. That is his luck or your luck. How frequently? Next question. 3 to 4 times in a year, the book says. But at the same time, if the patient is coming back to you after 4 to 6 weeks, another in wheelchair or something, you don't have any other option. You can't operate him or her overnight. So again you can inject this injection, but not very frequently, but there is no contraindication to that. Then people will tell you about the sepsis. Mind you, if you are having antiseptic precautions, no sepsis. We must have injected more than 20,000 joints till now, no sepsis at all, provided if you have taken precautions. Word of caution. When you are injecting the patient, please tell the patient that you may have severe pain for next 24 hours or so. If you are mixing lidocaine or lignocaine along with steroid or methylprednisolone. Why? Because if you mix these two drugs, it crystallizes the methylprednisolone. Those crystals themselves irritate the synovium and cause intense pain. And the answer is very simple. Ask the patient to take paracetamol and cold sponging. The patient will be benefited. And of course, rest for 2 to 7 days. Rest doesn't mean bed rest. Ask him to continue his daily jobs, daily thing, but he should not run or jog or go for a long walk for at least a week or so. Next comes hyaluronic acid. Basically, this is vitreous fluid with uronic acid. What is synovial new fluid? Basically, is a lubricant and shock absorber. When the age is elderly or when there is some inflammation, what happens? The concentration and molecular weight of this synovial fluid is reduced, or hyaluronic acid. So what do? We have intra-articular hyaluronic acid. The ACR recommendation does not permit that. They do not recommend it. But what this meta-analysis found that there is an inconsistent conclusion, and someone found that there is small but significant efficacy. What happens, what practically we have seen, if we give say this injection to grade 2 or grade 3 of osteoarthritis, the pain is subsided in next 3 to 4 weeks. Tell the patient to have some patience. What the patient they want? Immediate relief. For that, our few of the rheumatologists, they have started mixing 40 milligram of methylprednisolone along with hyaluronic acid but I have done in only one patient, and that patient came back with the pain, so I have stopped giving like that. So it is not a chondroprotective effect, does not have any effect. As I told you, American authorities also, they do not recommend it for mild to moderate arthritis. They just recommend it for the patients who are awaiting total knee replacement. Now that is the theory part. What we have experienced in our Army Hospital R&R, we started using this drug right from 2010, but the data collection was from February 2011 till August 2014. Although I should not take the pharmaceutical name, that time only 6 ml of hyaluronic acid available was of Synvix. So we started using that. We had total 353 patients. That is not important. What is important is 543 knee joints are injected. And 216 patients of grade 2, grade 3 are 299, and grade 4 are 28. Why grade 4? Some patient demanded, and some patients who were already given a Synvix injection, they saw, Doctor, we had relief to give us more. The on demand also we gave. That's only 28 patients of grade 4, otherwise we did not recommend for grade 4 of osteoarthritis. Adverse effects seen in 34 knees, post procedure pain minimal, but 2 patients had swelling also. Why? We forgot to take the history of allergy to egg protein. Please take that history. One patient, really switched us off. The patient told us that she will sue us. Because it was written in the literature that egg protein allergy patient we should not inject, and frankly speaking we did not read that. That was the first time I read that. So assessment of relief we did after 4 to 6 weeks. 94 knees out of 543, they did not respond at all. After 4 to 6 weeks they were jaise the, as they were. In 41 patients, the relief lasted for more than 3 years. That was a good thing about this drug. So repeat injection, 186 knees we gave, 6 months to 3 years. Before 6 months we should not give it, and 3 years, after 3 years also, some of the patients I will tell them about that. They came back after 3 years, Doctor, for 3 years I was absolutely without pain, now give me that injection again. Maximum injection in one knee we gave 3. So when do we repeat injections? Simple formula. If the patient had relief from the first injection. Don't read all these things. Only one sentence is important in this. Case 1. If you see the X-ray of the same patients, 11 July 2011, we gave him almost grade 3 osteoarthritis there. For 2 years, the patient had relief. Radiologically, he deteriorated, but still he had symptomatic relief. Next patient. Look at this patient. After 3 years, the patient came to us with significant deterioration to almost grade 4. But symptom-wise, the patient was doing better. She was not on any steroid or any analgesics. But for for 2.5 years, for last 6 months, she started gradually having pain. And with the hesitation, she came back to us. Doctor, will you like to give me injection again? Not Vache. I said, yes, why not? So we gave after 3 years with this patient. Again became all right for 6 months. I don't know what happened after that. Case 3. 3 injections. 2009, 2011, 2014. Ladies and gentlemen, that's why the preservation of joint is important. We should not go just by seeing all these, we should refer this patient to surgeon. No, if we can withhold this surgery with these drugs, whatever drugs we use, continue with that. So lifestyle modification. We Indians are very fond of squatting, sitting on ground, sits up and using our climbing stairs and up this thing. If we compare our day-to-day lifestyle with Westerners, what do? We get up early in the morning, where do you go? To the washroom. Which kind of commode we use? We means our population, Indian type of commode. The Westerners use the Western type of commode, no squatting available. After that, he also takes bath, we also take bath. How does they take bath? By shower, standing. How do we take bath? Bucket bath. Either this or the stool, it is available in the market. We never take shower bath. Of course, those who are educated and those who are, coming generation, they take showers. But that is the squatting position, but everything is squatting. After getting clean, after taking bath, what do? Our ladies, they pray. How do they pray? By sitting on the ground. And how frequently? Every day. Westerners, they also pray. Once in a week, either standing or sitting on the benches. They never squat. And look at this lady, how she is sweeping with squatting. How she is going up and down in her house. And look, this is my hospital. It is clearly, the request is written, those who are healthy, please use ramp. But look at these patients, they are not using ramp. Ramp is used by me, my colleagues, that too after a lot of insistence, and my commandant. No one uses ramp. Everyone uses staircases. So what will happen? Osteoarthritis patient, already the cartilage is damaged. You are giving more pressure, more cartilage erosion, and more symptomatic. So we have to change your lifestyle. Please tell your patient not to squat. Exercises, the 4 Ds. Do it regularly, do it correctly, do not overdo it. These exercises for prevention, it should be like, brushing your teeth. It should be gentle and continuous for the rest of the life. Not that 6 months ke liye gym chale jao, something like that. Free cycling. Give the lady or the gentleman a cycle at home. It should be resistant free cycle. But what we have seen, people use cycling to reduce weight. Ladies and gentlemen, let me be very, very clear. It's not the tool to reduce your weight. It is basically to for the free movements of our joints, but do not overdo it. And the best exercise is basically brisk walking. And there is a formula for brisk walking. You can tell your patients, not more than 50 minutes at a stretch, not more than 5 kilometers at a stretch, not more than 5 days in a week. You can give you should give 2 days rest to your knees, but it should be brisk exercises. Ask your patient not to have any high impact games like volleyball, basketball, badminton and all those things after the age of 50 years if he wants to preserve his knees. And of course, skipping in a soft ground. Weight management. It has been found that if you reduce the 5 kg of weight within 5 weeks, 25% of the patient's symptoms, they just go off without any analgesics. So that is the importance of weight loss. But do not ask a patient who is lean and thin, ki apna weight kam karo. His weight is already less. Those who are having heavy weight. Braces, the studies showed not much relief, but advise braces because it stabilizes the knee joints, and depending on which category of patient you have. We have officers who play golf like this. For their stability of the knee joint, we prescribe braces. Otherwise, the feeling of giveaway, once we are walking fast, or the patient of osteoarthritis suddenly feel as if the knee has given way. To stop that feeling also, we can advise braces. The most unused thing in our society is cane, which Dr. Mahendranath will agree with. In UK, sir, most of the elderly gentlemen, they still use cane. Why we don't use? Because we feel ashamed, ki log kenge buddha ho gaya. Something like that. But it should be of correct size. This study showed in 2012 that it could be used to diminish pain and improve function and some aspect of quality of life in participants with knee osteoarthritis. So scientifically it is proven that cane is good because it transfers your weight. It reduces the weight from your knee joint. Last but not the least, the advances are that one day will come when we will grow chondrocytes, and these chondrocytes can be transplanted into cartilage. There they will grow and develop into cartilage. So future is that we may change or replace articular cartilage by new cartilage, like we are changing a tire or tube of a cycle. So why preservation of knee is important? Ladies and gentlemen, original is original. You know who was the first He-Man of Indian Bollywood cinema? Dharmendra. Could any Khan brothers, Amir Khan, Shah Rukh Khan, Salman Khan or John Abraham could replace him? No. So original is original, number one. Original joint should be preserved. And you can't change the nature unless nature comes back to you with some natural calamity. That calamity is grade 4 osteoarthritis when the patient is unable to do this. And if you do the surgery at early age, say 60 years, what is the lifespan of implant? 20 years? So at the ripe age of 20 years, again he will require surgery. So try to advance it as much as possible so that the patient will require only one knee surgery, because 85% of us will die at the age of 85 years. 90% of us will die at the age of 90 years. Of course, that kind. So medications and non-pharmacological methods, they do work, as I told you, with the references. I am not all those metastasis analysis and everything. So ladies and gentlemen, if we start early, we can delay by following the healthy lifestyle. As I told you, do not squat, give this patient give good pain relief to the patient, give all those non-pharmacological things. And the next question comes to you. Once you prescribe that, okay, you are not well now, you have to get your joint replaced. Doctor, when should we get our joint replaced? He comes to me, he goes to you and 10 doctors, he will go to 50 doctors. So what should be the answer? When the patient is unable to perform day-to-day activities of living. the patient is writhing with pain, he or she cannot go to the toilet, she cannot go to her temple, she cannot change her dress, she cannot eat her food properly, she cannot go to the kitchen. Why to have that kind of tortuous life? That is the day of indication for surgery. Quality of life, as I told you, higher strata patient. If the patient is very fond of golf or very fond of walking, if he is unable to play his golf, especially in army, we say, okay, please go ahead with joint surgery. So send that patient to a reliable surgeon like my friend Dr. Acharya, and you relax. And after this, I will be relaxing, and the journey will be continued by him. Thank you, ladies and gentlemen.